Hi, my name is Dr. Robert Dunn. I'm the Chief Scientific Officer for Clinilabs Drug Development Corporation. And this is a fireside talk. And we're lucky today to have Dr. Ron Postuma to talk about Parkinson's disease. He's a professor of neurology at McGill University in Montreal.
Pleasure to be here.
Maybe we could start off our talk about Parkinson's disease with clinical features and characteristic symptoms.
Right. So the clinical features, they're extremely diverse. Basically, you can divide them into motor and non-motor. So we still define Parkinson's disease based on its motor symptoms. So that really means, slowness of movement, bradykinesia, plus one of rigidity and or rest tremor. And that basically makes the diagnosis of Parkinsonism, and then you've diagnosed Parkinson's. And that's still the major feature that we deal with early on in Parkinson's disease. We're also, however, recognizing that it's a very diverse disease, and so the dopaminergic the movement disorder features are predominantly related to the dopamine system, which isn't working very well, and so you get a signal not to move, and so you move slower, and the tremor doesn't come out. But then there's degeneration in many other areas as well of the nervous system. So there's autonomic features, so blood pressure drops and constipation, having to go to the bathroom, the bladder is too frequent. There's sleep features such as somnolence, REM sleep behavior disorder, sleep maintenance, insomnia. Some psychiatric things, a lot of anxiety happens in Parkinson's disease, and cognitive impairment can occur as well. And so there's an extremely long list of manifestations involved in Parkinson's, that's for sure.
Thank you, Dr. Passman. Maybe we could talk a little bit about the course of illness.
Sure. So, the course of illness is different in everybody. One of the things that's fascinating, and we'll talk about it maybe a little bit later, is that, the course of illness starts way, way before you ever present to a doctor with the movement disorder symptoms. And in fact, it can be over 20 years that the disease is in one's brain before it ever clinically expresses itself. And so that's important to recognize that we got a person with a 20-year disease duration already sitting in my office with that what we call early Parkinson's disease. And so the course after that point is variable. Most of the time, these are people presenting with motor symptoms predominantly, and so we treat them with the motor symptoms, and they get a whole lot better, and everything's really good for a while. And then over time, one of two things happens, especially in young people. We can't keep the doses steady, so they're up and down, up and down. Dyskinesia, excessive movement when they're on, slow movement when they're off, etc. Or in other people, and sometimes the same people, the non-motor aspects that I was talking about earlier can come to dominate the clinical presentation. And actually, those are in fact the most important, by far, indicators of prognosis in Parkinson's disease. The best way to predict prognosis in Parkinson's disease is to ignore the dopamine system completely and focus on balance, gait. That's the only motor symptom that really works in predicting outcome. And then things like orthostatic hypotension, acting out the dreams at night, and cognitive impairment. Those are the ways that really tell us what's going to happen to a person.
Oh, I see. Maybe we could talk a little bit about some of the comorbid symptoms that are more prevalent amongst Parkinson's patients, like depression, dementia, and psychosis.
Comorbid sort of implies another disease. These are in fact caused by the disease themselves. And so depression is quite common in Parkinson's disease. I would say less common is a feeling of sadness and more a feeling of anxiety. Everything just overwhelms you. You get nervous about your doctor's appointments for weeks in advance, even though you know the doctor, he's a very nice person. They're still coming in, saying, I've been thinking about this visit for weeks. That's quite a common, I'd say about half of people will notice some change like that, whether it be mild or relatively severe. And then cognitive impairment really is mostly a different phenomenon, and it often starts with hallucinations. So people who see things that aren't there, that's the classic hallucination of Parkinson's disease. It's visual. That can be caused by, it's exacerbated by medication, so it could be driven by very high doses of medications. But in many cases, In fact, the hallucinations are the first sign that the cognition is becoming impaired. And people can sort of fall into what we might call dementia with Lewy bodies, very analogous to the sort of classic dementia with Lewy bodies, or Parkinson's disease dementia. Some people use those words. I think they're relatively interchangeable terms in Parkinson's disease. But these are, these are people who are having a lot of hallucinations, really quite profound fluctuations. So sometimes perfectly great, and sometimes, oh my goodness, where is he? Where is she? She's on the moon somewhere. A lot of sleepiness and fluctuation in alertness as well. And actually, with some of the medications that we use in Parkinson's cognitive impairment can really actually make quite a difference there.
Thank you. Maybe we could take a brief overview of the epidemiology, incidence, and sex relationships to prevalence and that kind of thing.
Yeah. So if you make it to sort of a ripe old age, well past 80, you sort of have kind of like around a 1 in 50 chance of developing Parkinson's disease in your life. That's clinical Parkinson's disease. And of course, if you add Lewy body dementia to that, it goes up a little bit as well. So it's the second commonest neurodegenerative disease behind Alzheimer's disease. And so, yeah, it's a common condition, that's for sure. It's very age dependent. The older you are, the more likely you are to get it. When you're very old, it can be more difficult to diagnosed because there's many things going on in your brain at the same time. And so often the diagnosis curves don't look like they're continually going up, but they actually really do. And for reasons that we don't entirely understand, it's a bit of a male predominant disease. So it's about 60-40 or maybe even 65-35 in some cases, but it's a consistent thing seen across populations, no matter who gets, no matter whether you're in China or in Canada or in US, it's relatively consistent. And the only exception to that is, of course, the genetically driven Parkinson's disease, which are still a minority of the cases where it's a single gene that you can say that caused your Parkinson's. We do know that Alzheimer's is more common in women, and so maybe there's something about competing risks going on there. Other risk factors for Parkinson's disease, a family history. There are pure genetic forms, but there's also genetic risk factors. And so people who have a family history of Parkinson's disease might be at, say, twofold increased risk on average, if you will. And then there's some exposures, pesticides and solvent exposures are the ones that we talk about the most. So they're not that powerful. They might double or triple your risk, but again, a 1 in 50 lifetime chance going down to a 1 in 25 lifetime chance, something like that. But yeah, and then there's a long list of other risk factors, which we probably don't need to go over.
You touched on this a bit earlier, but maybe we could talk about the neuropathology involved in Parkinson's.
Right.
And maybe we could contrast that with related conditions like Lewy body dementia and that kind of thing.
Perfect. Yeah. Okay. So the hallmark of Parkinson's disease, say on an autopsy, would be the deposition. Would be two things: degeneration of the substantia nigra. That's the dopamine area that helps control the movement, as obligatory. And then, in the vast majority of cases, you see deposition of an abnormal protein called alpha-synuclein. Which occurs in exactly the same distribution that reflects the clinical symptoms. And so we think that is certainly important pathologically, pathophysiologically, but we don't exactly understand why. Those are the major hallmarks on autopsy. And we actually now know that, in fact, we can see this not only in the brain, but in the periphery as well. So skin biopsies, for example, are able to detect abnormal synuclein deposition as a diagnostic feature of Parkinson's disease. You had mentioned dementia with Lewy bodies. Under a microscope, there is no difference. No pathologist can tell a person under a microscope if they've died of Parkinson's or dementia with Lewy bodies. And so we do not consider, at least in the Parkinson's community, they are not considered to be mutually exclusive conditions. In other words, you can have Parkinson's and you can have dementia with Lewy bodies at the same time, dementia with Lewy bodies. If a person is presenting with dementia much before they would ever get Parkinson's, or even in the absence of Parkinson's disease, we think that the co-pathology of dementia with Lewy bodies is very important, and the major co-pathology is Alzheimer's pathology. I like to tell my patients who have DLB, it's kind of like a combination of Parkinson's and Alzheimer's at the same time. I really do think that is the case. And if you get dementia very late in the course of your Parkinson's, after many, many years, it's really dominated by the synuclein. If you get dementia very, very early, it's dominated by amyloid, and everywhere else is somewhere in between. And I think that really helps to explain the spectrum that we see in our clinics, where some people present to a memory clinic and some people present to a Parkinson's clinic with essentially what is a similar overlapping condition.
Mm-hmm. Thank you. Maybe we could take a look at existing treatments for Parkinson's disease, touching on benefits and adverse effects.
Right. So there's two major categories of treatment, okay? And the first one is the easiest to talk about, which would be a neuroprotective treatment. So this is something that would slow down the underlying neurodegenerative process of Parkinson's disease. This is, of course, extremely important to try and develop. And the short answer is we don't really have any neuroprotective treatments that we know work right now. If we did, everybody with Parkinson's would need it by definition, and therefore it would become a very big deal. We don't have those now, but that's a very active area of research. The rest now is, so every treatment that we have is essentially what we term as symptomatic treatment. And so we're actually trying, not changing the underlying pathology necessarily, but changing the way the circuits function, changing the way the brain functions so that you feel better. And in Parkinson's disease, we're exceptionally fortunate that we have exceptionally good symptomatic treatments. So the dopamine area I talked about, the substantia nigra degeneration, that's the easiest thing to target. And so essentially the substantia nigra makes dopamine, you don't have it, we give it back. And you can do it via directly dopamine, which is Sinemet levodopa, the standard forever treatment of Parkinson's disease. Everybody should get that at some point in their illness. And you also can do it via other tricks. For example, dopamine receptor agonists, so increasing the dopamine function that way, preventing the breakdown of dopamine, for example, with MAO inhibitors or COMT inhibitors. Other neurotransmitters have also been looked at in terms of changing the balance of dopamine. They all work very, very well. They continue to work throughout the course of the illness. But what happens generally is, like I said, one of those two things. Either we can't keep the dopamine doses stable, and so they're up, down, up, down, up, down. Tends to be young people who run into this problem a lot. The medication is great when it works, but then they get the dyskinesia. And in those cases, we can use continuous therapy for Parkinson's disease. So we used to be giving it mostly in the stomach. Now it's being switched a little bit more to under the skin formulations of either dopamine or dopamine agonists. And then there's the surgical approaches. So you essentially inactivate the abnormal circuit with surgical approaches, whether you do that with focused ultrasound, which is essentially burning a hole, or you do it with a wire and inactivating that region, which of course is a little bit more reversible. But more invasive. And so that's sort of the very short summary of the symptomatic treatments for motor symptoms. And then don't forget this whole massive list of all those non-motor symptoms. We don't have amazing treatments for most of those, but nobody should have to deal with constipation. We usually can fix that with a variety of bladder dysfunction, anxiety, depression, and cognitive impairment really do respond partially or in some cases completely to our symptomatic treatment. So every Parkinson's specialist who's worth their job needs to be actually pretty good at some of the general aspects of medicine and can't just treat the motor system.
You touched on it a bit already, but new treatments that are in the pipeline, in development.
So, in those two categories, the dopamine treatments, the symptomatic motor treatments that are in the pipeline are mostly having to do with just finding a way to get what we can get with the levodopa all the time consistently. So the difficulty with levodopa is that it doesn't get absorbed reliably from the stomach. It's absorbed from the small intestine. The stomach is abnormal in Parkinson's disease. So you would think, let's just infuse a small amount straight into the stomach, or, a little, maybe the patient takes half a pill every half an hour and everything's great, but that doesn't work because the stomach can't be counted on. And so we bypass that, for example, with the duodopa, putting it straight into the small intestine, but that's quite invasive. But so most of the treatments in the pipeline symptomatically for dopamine are just solving the chemical problem. If we can make levodopa water soluble, infuse it, get it in the skin, inhale it, find some way that we can get steady streams of levodopa throughout, or get better agents to sort of keep the levels of dopamine up on a consistent basis so that patients aren't doing up and down. And then there's the non-motor treatment pipeline. I think there's probably too much to discuss there because it would be details of each individual one. There's new antidepressants all the time, et cetera, et cetera. And then in the neuroprotective pipeline, there's a few approaches that are being tried and are very interesting. The obvious approach is to target synuclein itself. And so there are several agents in either phase 2 or phase 3, phase 2, right now, looking at that. Some of the synuclein antibody treatments are the ones that are the farthest ahead as having published phase 2 data and still being researched. But many ways to prevent aggregation, to decrease total levels, etc. There's a panoply of these synuclein-targeted therapies. Another category of therapies is to target the genes that we know. So if a gene can cause Parkinson's, that gene must be involved in the pathophysiology of Parkinson's, at least that person's Parkinson's, but maybe a Parkinson's in general. And so the two genes that are getting the most attention is one, LRRK2. LRRK2 is a kinase. You can inhibit a kinase. You can drug it very easily. And so LRRK2 inhibitors are in trials right now. And the other is GBA, glucocerebrosidase A, which is an important lysosomal enzyme that may be involved in synuclein processing and is probably the most, numerically at least, the most important gene in Parkinson's disease, especially as a risk factor. And so maybe we could correct that. We could help. And then there's a few other approaches helping mitochondrial function, for example. Anti-inflammatory approaches are getting increasing prominence because there's very early inflammation in Parkinson's that may settle down as the disease progresses. So the pipeline is rich, I would say. We have lots of defeats, but there's always a few coming up to the fore, so we're hoping for the best.
Thank you very much, Dr. Postuma, for a wide-ranging talk in depth on Parkinson's disease, symptoms, causes, and treatments, and new areas of research.
Thank you. It's a pleasure to be here.